I would say that we engage community leaders as well as people who represent the participant pool.
Hello, I'm Rachel Deere, host of today's program, COVID-19, Keeping Up with a Moving Target. This is the July 10th update of DKB Med Radio's Coronavirus Educational Series. Thank you for joining us. This activity is jointly provided by the Postgraduate Institute for Medicine, DKB Med, and the Institute for Johns Hopkins Nursing. Today's program is accredited for ANCC and AAPA credit, as well as AMA PRA Category 1 credits. Please visit our website for complete CE information. To attest for credit, please visit covid19.dkbmed.com. There, you will also find all of our previous COVID-19 programs and have access to other free CE programs on a wide range of topics. The slides for today's webinar and previous webinars can be found under the Resource tab. Today's learning objectives are: describe the disparities in COVID-19 populations, discuss COVID-19 trends found within the Black and Latinx populations, and discuss strategies to mitigate and eliminate risk and disparities in these populations. This activity is supported by an educational grant from Pfizer Incorporated and in kind by DKB Med. All activity content and materials have been developed solely by the activity directors, planning committee members, and faculty presenters, and are free of influence from Pfizer. With us today, we have Dr. Paul Auwaerter, Clinical Director of the Division of Infectious Diseases at Johns Hopkins School of Medicine. He will be interviewing Dr. Kathleen Page, an Assistant Professor in the Division of Infectious Diseases at Johns Hopkins School of Medicine. She will be discussing disparities and their impact on COVID-19 in the Latinx community.
Thank you, Rachel, and I wanted to thank Dr. Kathleen Page for joining us, who's an associate professor in our Division of Infectious Diseases at Johns Hopkins here in Baltimore. Kathleen, you bring a wealth of expertise and innovation, often for more disadvantaged groups, working for groups in terms of healthcare. So I thought we might tackle two issues that are sort of large, but see what your thoughts are on that. The first has to do with sort of public policies and responsibilities, not only for government and society, perhaps for people that are more socially disadvantaged. And then talk a little bit about research efforts, because that's so important really for helping us advance and try to overcome the pandemic. So why don't we first start off with the concept that I think a lot of people have embraced early, and that is a public charge for COVID. I mean, there's been stimulus checks. There's been some guidance to employers and schools and institutions, as well as individuals, to take responsibility for mitigating risks and so on. What's your view, whether it's for Blacks or the Latinx community or whatnot? What are some of the things that you feel from a very high level that are sort of forefront in your mind in terms of really still impeding a bit as to, you know, helping groups, especially that now seem to make up so much of our hospitalized patients in many cities?
Yeah, so yeah, thank you, Paul, for that question. I think, you know, this COVID-19 has really unmasked disparities in our system in ways that, you know, we've seen that with other infectious diseases, but it's been very remarkable with COVID and so quickly because it's progressed so quickly. And when I say disparities, I also think that it uncovers consequences of some of the policies that we have. You asked about the public charge, so I'm going to speak very specifically about the impact on immigrants, because that's what that relates to. And also because, as you know, there's been such a disproportionate impact in our system in Maryland and in other areas on Latinos, and in particular Spanish-speaking Latinos. So the public charge is this policy that sort of went up through various iterations over the last 2 years, but then finally was approved on February 24th of this year, ironically right before COVID really became a huge epidemic in this country. But basically what it says is a policy directed at immigrants in this country who may be applying for a green card and then pathway to citizenship. And it counts against them, it counts against the application, the use of public benefits, such as food stamps or other things. Now, many immigrants don't even have access to these benefits, but sometimes their kids do because their kids are American. And so, for example, immigrant parents may have American children and may be applying for help in that way. For some people, when they first hear about this, they think, well, that makes sense. Like, why would we take any immigrants here who are not making enough money, basically? And I guess the answer I would have is that, as many of you may know or not, immigrants in this country really provide many of the essential low-income jobs in this country are really done by immigrants. And these include jobs such as in the service industry, in the restaurant industry, in the construction industry, but also, for example, healthcare aides who do an enormous job taking care of elderly people in this country who are American. And so my only comment about that is that the people who may need some extra help are not necessarily people who are not working. They are working. It's just that the issue here is that the jobs are very low paying. Now, having said that, what does this have to do with COVID? What has happened, and really we've seen that happening in the last 2 years, is that this policy has really dampened the use of services in general in the immigrant community. And although the policy specifically, if you talk to lawyers, really only impacts a very small group of patients, those that actually, groups of immigrants, those that are maybe undocumented but have a pathway to citizenship, or maybe they are documented and a pathway to citizenship. For most people, that, especially those who are undocumented, this is not even an option. Nonetheless, almost all immigrants in this country wish and dream of the time that they will have legal status and can work here legally, and they recognize that that's the best pathway to success. So everyone has that dream. And what's happened is that policy alone discouraged people, all immigrants, from using any sort of public service. And there's been good data documenting, for example, the disenrollment of American kids from Medicaid and from food SNAP benefits and all that, because their parents were immigrant and they were worried that that would impact their future immigration status. So sorry for the long explanation, but that gives you a sense of what this public charge does. So when COVID-19 actually came, there was a message in the governmental site saying, don't worry about the public charge. We've said all along that you can't seek benefits or care or whatever, but in this case, please do, because this is a public health emergency. The problem is that, first of all, I'm not sure who goes to that site and listens to that. And also, this message is coming from the same organizations that have not exactly instilled trust in this community. These are the same policies that have been anti-immigrant. So, the reality is that most people have not gotten the message that it's okay to seek COVID care. And even if they've gotten it, they don't trust it because it's inconsistent with what they've heard about immigrants for the last 2 to 3 years. That's an example of how our policies, which may look on the surface to have nothing to do with public health, but when you exclude a population from anything, from certain things, and when a public health emergency happens, where public health, the whole definition of public health is that we're all interconnected and that the health of one person impacts the health of others, and COVID-19 has clearly shown us that, it's hard to respond because we need a unified response. We need to engage the whole community. And if some people are disengaged because they're hard to reach because they've never been engaged, or they may be engageable, but they don't trust the systems that are engaging them, it just becomes really, really tricky. The other piece is access to healthcare, which again, this community has been excluded from. And so when they need to get care, or when they get a call from the health department telling them that they're doing contact tracing, they just may not trust that or may not seek care. And finally, I would say that the exclusion, again, of immigrants from so many things makes it difficult for them to access legal recourse, even when they have a right to legal recourse. And so, for example, in the occupational setting, we certainly have seen that occupational exposures have been a big issue in this community. We've heard about the meat and poultry industry, but also in other settings where these workers are not necessarily given the adequate protections. But again, they are unlikely to report this to authorities because any interaction with authorities to them may feel like a risk of exposure, of exposing their own immigration status and potential deportation. So it's just like this confluence of circumstances that make it difficult for this community to advocate for themselves and easy to exploit and then create the conditions that lead to transmission.
There's just so many issues, just even in the best of times, that it, as you pointed out, it really magnifies at so many levels. And of course, people want to maintain their own safety and dignity for themselves and family members, that they don't want to take risks. And unfortunately, I think we've seen time and again that people are not taking care of their underlying health issues, such as diabetes, which seems to be such a big risk factor for COVID-19, or if they are coming to hospitals only in extremis. They have already they're not coming at the first signs or seeking medical care. It's far longer, and especially now as we're beginning to have some treatment emergence, I'm afraid some of these disparities might even grow more in this case, in terms of hospitalizations and mortality, which is just so unfortunate, as you point out, given the public health aspects of trying to control this. So,
yeah, I think I would say that two key points for anyone who's taking care of patients like this in this situation. I would say that I think the two priorities that I hear are money, and by money I mean like that's the concern that they will not be able to work and make it and feed their family, or that they could get bankrupt with a medical bill is really a huge deterrent to seeking services. And the other one is the fear of deportation and family separation. So family separation in particular is such a huge concern that people will not do things if they think it could put them at risk for that.
Yeah.
And so
And I think, what everyone can do, if you are taking care of patients, or to try to incorporate some of these key messages and really just steward those and try to make sure the patient understands it, and maybe they could explain to other family members so that, they have an example of, some of the services and support that might be available, even despite some of the challenges. And I think examples always speak much more than words, but we still have to point those out and tell people so that we can try to lower some of these invisible barriers that are really so important.
Yeah, I think being explicit about it is critical, because I don't assume that people know this. In fact, I assume they don't know this. And so while I don't interrogate patients about their legal status, I don't think that's relevant. I like to make general comments. I'm like, I'll say things like, a lot of people are worried about their medical bills, but the good thing is that in this case, there's help. It doesn't matter if you have insurance or papers. I sort of throw it in there. So I think that is important to state explicitly. That sometimes opens the conversation, and patients will ask more questions. And if they're comfortable and they want to do that, we can delve in more. But at least I feel like it's important that they hear it once. And I have to say that the relief that people sort of express when they hear that is remarkable. I mean, I have seen now, unfortunately, a lot of patients, well, fortunately that they're coming off the vent, but unfortunately that they were on the vent. But it's sort of honestly heartbreaking that so many of them are worried about when can they go back to work and how are they going to pay for this. And that, I think that's something that in the context of all that they're going through, we can reassure them. And, of course, talk to our own hospitals and make sure that that's happening. But there is, the CARE Act, although it excludes, these patients will not get the stimulus check, there is funding for the healthcare, and the healthcare will be covered through that.
Those are fantastic examples I think we can all incorporate and try and remember. On a separate kind of set of barriers, I think, just to touch on a complex topic, but We're trying to learn about COVID-19 and find interventions against this novel coronavirus, and make sure that it works. Any kind of interventions work in all groups, and so many of our hospitalized patients now are Blacks, members of the Latino community, and others. And trying to engage in clinical research is always a challenge at any time. But can you speak to just a couple of issues that you feel are important, whether you're in an institution doing clinical studies or not? I think it's important because if members of our community aren't being engaged, then you're, whatever results you have may not be as reflective.
Yeah, I mean, I think this is such another really important point, and especially with COVID, where we're learning everything so quickly, and the need for research is essential. So I think it's a balance between it's critical to be inclusive, and I really welcome the emails I've gotten from many people who want to include. Particularly, I get emails about including Spanish-speaking Latinos in research, and I think that is a welcome step. On the other hand, I have to say that we need to do it well. In this community in particular, at least the community that I work with here in Baltimore and Maryland, research among Spanish-speaking Latinos has been limited. In fact, they frankly have been systematically excluded from many research trials because it just sometimes feels like it's too much work to do things in Spanish or whatever, right?
Mm-hmm.
But now, is a time to do that differently. But what that means is that this is what I would call a research naive community. What does that mean? And it's also a community that's not only Spanish speaking, but also generally low literacy, has some difficulty, has not engaged with the health system very much, and less so with the research system or research activities. So it's really imperative that we start from scratch in terms of explaining to people what is research about, really making sure that people understand the voluntary nature of research, that that it won't impact whether they access healthcare, their access to healthcare, or whether we treat them at Hopkins or not. Critical that I would say that we engage community leaders as well as people who represent the participant pool, and make sure that our consent forms are everything is in language that is easily understandable. I have found that in taking care of Latino immigrant patients, especially those that grew up in a different country, where sometimes the medical system is very paternalistic, so very top down. You just do what the doctor tells you. The worry here is that if a researcher comes and says, and then there's a consent quickly, that the patient may just say yes because they just are used to just doing whatever someone in a white coat tells them to do. And certainly I think we all recognize that that's not how we want to engage our participants in research. And I think there's again the issues of mistrust and communication, and I can give a specific example perhaps to illustrate this. So we all are pinning our hopes on a vaccine. Like having an effective vaccine could change everything for COVID. As these vaccines trials are coming to play, it's important that vulnerable and at-risk communities are included into vaccine trials for various reasons. One of them is because we want to make sure that the results are generalizable, but also because if there's benefit to participation, like we want to make sure that our community doesn't get excluded. And so I feel strongly about that. On the other hand, I also recognize that some people, like in any group, some people would never be part of a vaccine trial and some people would. And we just have to provide the information and so in a way that people can really make that choice for themselves depending on their preference. I have been, as part of this work that we're doing with Immigrants, participating in a very local show called Somos Baltimore Latino, that's in Spanish, and it's every Friday, and it's a question answer where people call in and ask the doctor whatever question they have. And generally those questions have to do with care, whatever, But a few weeks ago, the producer of this show called me and said, we have to have an emergency show right now because there's this rumor that's going viral on Twitter or some social media that patients that come Latino and Black patients who come to hospital, not necessarily to Hopkins, but to hospitals, are getting injected and killed. And there's some experiment going. And so, obviously this is false news, but, it's sort of spread. And sometimes in communities that have been marginalized, that may ring true to them. They hear in the news that Blacks and Latinos are more likely to die in hospital, and then they hear that there's this injection going on, and they put two and two together, and they think that this may be happening. So anyway, we had a little bit of an emergency doctor question answer, and the most helpful part of that conversation was that as I was speaking and people were actually texting in their questions and what they had heard or whatever, we had people text in who had been patients at Hopkins and said, no, I survived, they treat me, they did all these things, and this is how it was. And that was incredibly helpful, and so much more helpful than me telling them, no, don't worry, because why would they trust me? But
Right.
when we heard from patients, I think that really changed the tone of that conversation. And I think the same with research. I think there's people right now who have engaged in research and have had a good experience, and they can speak to that, to the community. But I think, again, always recognizing that some people, it's not going to be for them, and that's okay. That's the same as it is for us.
I think your points are really so sound. I was a house officer in the 1980s, and then predominantly a Black population in hospital, and that old chestnut that patients were experimented in the hospital. So don't go to that hospital because you'll be experimented on. Were quite prevalent, and some rightly represent fear. No one wants to go in the hospital. There's a lot of unknowns. You're not there. We work in it every day, right? But they don't know. But a lot of it just reflects mistrust with institutions and communities. And I think, Kathleen, you've really done such wonders trying to help break down barriers and make institutions that have been around a long time much more sensitive and engaged with communities as much as possible. I think we have so much more to do, as recent events have documented across the United States. But wanted to thank you for spending some time today to talk about these. I think I learned a lot, and hope to incorporate as much of what you said as possible. So really wanted to thank you.
Well, I'm going to thank you, Paul, because I've learned so much from you that I guess this is payback. And thank you, Rachel, for having us.
Thank you, Dr. Page and Dr. Auwaerter, for an enlightening discussion about a very important topic. As a reminder, to claim credit, please complete the evaluation at covid19.dkbmed.com and select today's activity. You'll receive your certificate immediately after. Any questions or issues, feel free to email us at the address listed. To submit questions, please send them to qa@dkbmed.com. That's Q as in question, A as in answer, @dkbmed.com. Don't forget to access our resource center at covid19.dkbmed.com. You'll find a range of information, including the latest COVID-19 data and statistics, medical society guidelines, and resources in Spanish. Again, thanks for joining us, and thank you for your dedication to your patients with COVID-19.